Thank you, Dr. Malik, Dr. Doval. Thank you, Shwam, for the wonderful invitation. So, what happened with COVID and breast cancer screening, you can see in this graph, right? Actually, this graph represents the stock market of Sri Lanka, but it's no different from what happened to screening with of breast cancer with COVID. And if you look at YouTube, you will find lots and lots of videos that talk about experts giving their comments of what is the problem of screening and what are the consequences and how many lives are going to be lost. But at the end of my talk, I will be giving you a very controversial statement, and I will definitely like to hear the feedback from you guys. So if you look at worldwide meta-analysis, and that was published this year, 994 articles. 7 of them were registry based, and this represents 48 lakh cases, okay? 18 countries, and the drop in the rates of breast cancer screening was between 41 and 53%, and the drop in the breast cancer diagnosis was 18 to 29%. And obviously, the impact was more in countries where there was a lockdown that was announced, like in India. Now, another evidence of whether COVID-19 adversely affected breast cancer screening. This is 39,444 women. Control group was before COVID, January 19 to March 20. Pandemic group was March 20 to September 20. And this terminology I will use in other slides as well. So control group is before the pandemic and the pandemic group is during the pandemic. This data is from 7 academic and community centers in USA. And they looked at screening mammography, diagnostic mammography, as well as breast biopsy. And they said that there was a significant reduction in all 3 of them during the pandemic. This is data from Taiwan, and this is to tell you that it's not just breast cancer screening, but screening for other cancers which are also affected. And in here, you can see that the sharpest decline was for oral cancer, which was as much as 50%. Let us look at healthcare workers who are supposed to be educated, who are aware about what is happening, and therefore should take better care of health, like you and me. This was in the NCI funded network in United States, 794 healthcare workers. And you can see that overdue screening existed for breast mammography in almost a quarter of them, colorectal endoscopy in 39%, and lung cancer CT tomography in as many as 90% of patients. So the more intense the screening, the less is the chance that there will be compliance during the pandemic. This is comparative data of reduction due to pandemic in United States. Again, control is 2019 data, 2020 data is the pandemic data. Screening mammography reduced by 44%, p-value is very highly significant. Diagnostic mammography reduced by 21%, also statistically significant. But breast cancer surgeries that reduced by 11% was not statistically significant. What about inequalities? Do all the races and socioeconomic patients have the same problem? The answer is no. Again, you can see that this was a cohort where patients, or not patients, people who were screened 2 years ago and then subsequently were due for screening were evaluated. So the control cohort, initial screening was 2017 and second one was due before the pandemic in 2019. That was 18,197 patients. In the pandemic cohort, 16,391 people where the second screening was due when the pandemic occurred. And this said that the higher adverse event was seen in women who could not afford private insurance. So there were Medicaid insurance, and in the Asian race. And I think you should remember this. Now, what about time interval during the pandemic? This is now for patients who had paid or private insurance. Okay. So these are educated and probably upper middle class or rich people. The time one was the control was in 2019, the pandemic was 2020. And you look at the screening rate, in the month of April, 2019 was 4.2 to 2020 was 0.5, dramatic difference. But by June, that difference had come back. So there was a fear at the beginning, but then as the pandemic continued, people were more worried about other things as well. There were two computer modeling publications that I'm going to allude to. The first one is from United States, the other one is from United Kingdom. This modeling was based on a pandemic that lasted for 6 months. Okay, we know that the pandemic was much longer, but what if it was only 6 months? If it was only 6 months, by 2030, the projection was that there would be additional breast cancer deaths of 950 due to reduced screening, 1,314 due to delayed diagnosis for symptomatic patients, and 151 due to reduced chemotherapy in hormone receptor positive early breast cancer. Similar modeling from United Kingdom, screen delays was 14 lakh women. Screen not done was 7.5 lakh women. And it said that there would be a shift from screen detected to symptomatic patients in between 2,500 to 4,100 cancers. There would be additional cancer deaths of 148 to 452. Deaths due to screen detected tumors would be 164 to 221. And deaths due to DCIS progressing to invasive cancer would be between 71 and 97. So people have really spent a lot of time and energy and technology to identify exactly how many excess deaths could occur. Now, what were the barriers to screening? Obviously, everybody understands that there was a barrier, but let us look at it formally according to the publications. So there are three levels of barriers. One is the policy level. For example, the announcement that all elective procedures are to be delayed. The second could be organizational level because there is a backlog of patients waiting. And the third is individual level because of patient cancelling going to the hospital or the healthcare facility. Fear drives the postponement of screening. It's very logical. And fear of contamination was the reason for more than 50% of cases. Now, what happens about the fear in a patient who already has breast cancer, probably has been treated, now in complete remission, but there's a fear that my breast cancer may come back also. So these patients, 4,831, had distress and concern regarding the pandemic. But on top of that, they had distress about treatment plan interruptions and delay, dysfunctional communication with the medical team because the medical team was busy elsewhere or was not available, and difficulty in access of medicine and food, especially in the countries where there was a lockdown. Now, what is the effect of this delay? And in NHS UK, they said there is a 2-week wait pathway between the GP diagnosing and getting an appointment with a specialist, breast cancer specialist in an NHS hospital. So as a result of this, what would happen? So they looked at patients between 2013 to 2016, that was 6,281 stage 1 to 3, that is non-metastatic breast cancer patients. And they said that 27% of these were predicted to die in 10 years due to breast cancer. And because of the additional pandemic, additional lives lost because of this backlog. If the backlog was 25%, it would be 181. If it was 50%, it would be 361. And if it was 75%, it would be 542. Now, did anybody find innovative solutions? And the answer is yes. This particular group said that if the patient comes for screening, we will make sure that we provide everything that the patient needs on that particular day itself before the patient is discharged. So they said if the screening mammography is done and something is abnormal, we would do the diagnostic mammography and the diagnostic test before the patient goes back. And in the control, this was done only in 14.8% of instances, but during the pandemic, they were able to do it for 60.7%. So this is a solution to reduce the risk of exposure or contamination to the COVID virus by making sure patient spends the least amount of time in the hospital. What about solutions to the effect of the COVID-19 vaccine? All of us know that if the vaccine has been taken, it is possible that an axillary lymph node would interfere with the breast cancer screening mammography. And the recommendations from this, that was 1,027 patients of screening mammography who had also taken the vaccine, is that the lymph node is seen on mammography only if it is within 7 weeks of the vaccination. So either you do the screening mammography before the vaccination or wait for 8 weeks and then do the screening mammography. Now, what about the effect on breast cancer features? And this is newly diagnosed breast cancer patients, whether it is symptomatic presentation, grade 3 disease, triple negative breast cancer, first surgery, or neoadjuvant chemotherapy. And all those factors that are shown have statistically significant impact during the pandemic. So these were really badly affected. What about the impact of the stage on breast cancer? This is 573 patients, 376 in the control, 198 in the pandemic. As far as clinical stage is concerned, there was no difference. Nodal disease, statistically no difference, but 23% in control versus 27% in the pandemic. Metastatic disease, 2% here, 2% there. Neoadjuvant treatment increase in the pandemic, and this was because of the use of neoadjuvant endocrine therapy in stage 1 patients, which is something that many of us had used. Now, comparative data to reduction due to the pandemic in the United States, impact on clinical stage at the time of surgery. Screening mammography reduced by 40. I have shown this slide to you before, but look at the last point, which I had not shown you in the slide earlier. As far as clinical stage of the breast cancer at the time of surgery is concerned, there was no difference whether the screening mammography was reduced, whether diagnostic mammography was reduced, breast cancer surgery was reduced for biopsy. Clinical stage of breast cancer at the time of surgery was not different. Now let's look at something that is related to India, in the Indian context. Now I came across this on the web that says 50% of breast cancer patients in India die. I don't know from where this guy got these figures, but obviously it is incorrect. So if you look at early breast cancer in India, it's 30%. And why? Because of non-existent national level breast cancer screening program. Okay. And non-participation of women in any such program. This is because of a fatalistic attitude that we know. And there has been evidence that even among people who are supposed to know about cancer, their follow-up on mammography is not as appropriate as it should be. This is again difference between two cities, Chennai and Ranchi. And this was a cross-sectional study in 457 nurses. And you can see that excellent follow-up was there in only 16% of instances. So this is another data in Tamil Nadu. Those who underwent breast cancer screening, 39%, underwent cervical cancer screening, only 16%. And you can see that this included 1 cancer survivor and 8 people who were part of the healthcare provider team. So the problem is compliance. And this is I'm sure that you know this publication, Cluster Randomization Control Trial, which is the R01 trial, a very famous trial. Compliance was 71.43 and 64.93 for breast and cervical cancer screening, which is very good. Now this, for the people who don't know about it, is 20 geographical clusters in Mumbai, 10 screening clusters, 10 control clusters. Trial duration was 20 years. Okay, so this is very reliable data, especially because this included 1,51,538 women. Okay. This was the consort diagram. There was a 5% reduction in all-cause mortality in the screening arm, but not statistically significant. There was a 15% reduction in breast cancer mortality in the screening arm, but not statistically significant. 150,000 women, follow-up of 20 years, but no statistically significant data. This is the cumulative breast cancer mortality. You can see hardly any difference. This is now, is it only related to India or some other countries also have a similar data? So this is the data from the Canadian National Breast Cancer Screening Study. I'll just take 30 seconds more. 89,835 women, 2 arms, 44,000 in each. Deaths due to breast cancer over 5-year study, screening arm 180, control arm 171. Deaths due to breast cancer over 25 years follow-up period, screening arm 500, control arm 505. So overall probability of the survival absolutely identical. So whether it is India or whether it is Canada, breast cancer screening has been affected by pandemic. But all the fear mongers that say that this is going to cause a significant increase in the number of breast cancer deaths are speaking through their hat. This is Miller's conclusion. Annual mammography in women, see the last line, between the age of 40 and 59 years does not reduce mortality from breast cancer. Indranil Mitra, again a very good proponent of breast cancer screening, this is what he says. In the absence of a high level of awareness compounded by a fatalistic attitude to life, relative low incidence screening program may not be cost effective. And with that, I thank you very much for a patient here.